over was what they call an ARIN, and so it's called so it's warfarin because Wisconsin Alumni Research Foundation and ARIN on the end, and that's how it got its name. And for many years, that was the only agent we had to effectively anticoagulate people. The other thing that you'll probably hear with warfarin is that they'll say it's rat poison. Yeah. And the reason for that is that because it made cows die, they said, well, why don't we kill rats with it? And they basically put it in rat sack, and when rats ate it, they got anticoagulated and died from internal bleeding. So it became very commonly used in the 40s and 50s for that. And then some bright spark said, well, if we use it carefully, can we use it in humans to thin their blood so you get the advantages of having less blood clotting, but have safety without excess bleeding? And so they developed this test called an INR, International Normalized Ratio, that is a measure of how thin the blood is, and you try and keep that between 2 and 3 on warfarin. But warfarin, you have to have frequent blood tests. It's affected by food, so if you have spinach or silver beet or broccoli, that's got lots of vitamin K, so that messes up your INR. It's affected by alcohol, it's affected by antibiotics, it's affected by systemic illness. So it's a good drug, but it's a lot of mucking around. The alternative is now we've got agents that are called NOACs, or they're novel oral anticoagulants, but they're not novel because they're 10 years old, but they're still called that. And they're agents that work in the coagulation cascade by blocking here. There's a direct thrombin inhibitor, and there's also what's called a factor 10A inhibitors that block the development of prothrombin. And they've revolutionised anticoagulation because they're used basically as a replacement for warfarin in pretty much all circumstances. So for DVTs, for pulmonary embolism, for stroke prevention in AF, they're used almost exclusively. The only time you wouldn't use a NOAC is in a patient who has severe renal failure, so an EGFR or creatinine clearance less than 30, or if a patient has a metallic heart valve or mitral stenosis. You wouldn't use the new agents, but pretty much for everyone else, the new agents have replaced warfarin. And we haven't got them listed here, but there's the Bigatran, which is a direct thrombin inhibitor, apixaban and rivaroxaban, which are factor 10A inhibitors. But you'll see they're more and more used for anticoagulation in the context of hospital admissions, and they really have revolutionised that whole field. Now, antiplatelet agents are also used extensively in cardiology. Aspirin is the main agent, and it works by blocking cyclooxygenase, and it basically, what that does is reduce the ability of the platelets to stick together. It's an old therapy, it's a safe therapy, but it does cause bleeding to a small extent. We use it in patients who've had heart attacks, and often in combination with other medications I'll mention, and it's got a very good benefit-risk ratio in that situation. We also use it in patients who've had strokes, have blockages in the arteries in the legs or the neck or the heart, and in those situations the benefits outweigh the risks by a long way. There's been, until recently, we used to say in patients who had high risk of cardiac events like diabetics, like patients who were obese, who were smokers, that we thought using aspirin as a preventative medication would be beneficial. In fact, there's been 3 very big studies with tens of thousands of patients that have shown that even if you're at high risk, the benefits of aspirin and the risks of aspirin cancel each other out. So the consensus now is not to use aspirin in what we call primary prevention, and only use it in patients who've got established disease like heart attack, stroke, peripheral arterial disease, etc.
What about aspirin for like the chances of having preeclampsia while pregnant?
Yeah, I'm not so familiar with that, but yeah, I think they use it for that. But I don't actually look after many pregnant women, so I can't really tell you. But I think I've heard on the grapevine they do. But it's all of it's risk versus benefit. So if you've got preeclampsia or a tendency to it, I think my distant memory says yes, they do use it. But I'm talking about the general population. We've gone away from using aspirin for primary prevention and keep it predominantly for secondary prevention.
So does that mean that they say now, like they used to say, put an aspirin under your tongue if you thought you're having a heart attack?
Yeah.
Is that still correct?
Yeah, that's still correct because that's only one dose and it's better to err on the side of caution. And we know in the acute heart attack setting, if you use aspirin, it reduces mortality by about 20%. So certainly in the acute setting, it's fine. We're really talking about, we used to say if you had, say, a 50-year-old diabetic male who was a smoker, you'd say, oh, you better be on aspirin because it will prevent you having a heart attack. And in fact, the data would suggest that it doesn't do much in the way of prevention, but it does increase the risk of bleeding. And so we've gone away from using it in people who are just at risk and say, but if you have established disease, then you should take it long term, or something like you've suggested for suspected heart attack or preeclampsia, it's quite reasonable. But so we've gone away. So we use it really people with established disease. And if you're on it for that, you're on it indefinitely. Now, if you've had a heart attack, we also use often second antiplatelet agents. They're called P2Y12 inhibitors, ticagrelor and clopidogrel would be the main ones. And they block the platelet's function by another pathway, by blocking this P2Y12 receptor, and that enhances the antiplatelet effect of aspirin. So you're blocking platelet aggregation in two separate pathways. They reduce the risk of having another heart attack or a stroke or dying, but they increase the risk of bleeding. And so basically, again, it's a trade-off, but in that context of having a heart attack or a stent, the benefits outweigh the risks. In the context of not having any vascular disease, the benefits and the risks are the same, and so you basically, it's not recommended to be used. Generally, after a heart attack or a stent, we'd have aspirin indefinitely and have the second agent for 6 to 12 months, depending on the clinical context. And so you'll see more and more of that clopidogrel, ticagrelor with aspirin after a heart attack, stent, etc. Bleeding is an issue, but basically we say to patients, look, if you have a bleeding event, it's not good, but generally you'll recover from it without any long-term harm. On the other hand, if you have another heart attack or you have a stroke, you may well be left with a permanent disability. So it's better to reduce accept an increased risk of bleeding for the benefits you get from having preventative therapy. Aspirin, I sort of mentioned, given when a person's having an infarct, that's still pretty valid. The other agents, I suppose we haven't mentioned, are thrombolytics, and there, again, we think the genesis of a heart attack is you get a ruptured plaque in an artery, you form a blood clot, and that blocks the artery completely. And that's called an ST elevation myocardial infarction. And these agents were developed to be really aggressive blood clot dissolving agents. And 30 years ago now, we tested it and found if you gave it intravenously, that with that sort of artery, infarct, with aspirin you reduce mortality rates by about 25%. So for 20 years we had that as the standard treatment for a heart attack. These days, if you're having that type of heart attack, you go straight to the cath lab and have a stent done rather than having thrombolysis. And we haven't used thrombolytic therapy in Geelong for 10 years. If you have a heart attack in Colac or Camperdown or Hamilton, they'll use it because they can't get to the cath lab in time. If you have a heart attack here, if you can get to the lab within 90 minutes, you have a stent. If you can't, you have thrombolysis. And again, the risks are related to thinning the blood. You get bleeding, and sometimes you trade off one against the other. Increased risk of bleeding, having a big heart attack, and so it's always a balancing act.
That's me.
That's you?
That's me.
Okay. So that's basically a quick run through most of the contemporary drugs we use for blood pressure. We haven't talked so much about heart failure, but anticoagulants, antiplatelets, and So that's where we are. I'm sure in the wards you're going to see all of these drugs being used quite frequently. But I'm happy to answer any questions you may have about this or general cardiology stuff. So the floor is yours. Sure.
Why 90 minutes?
It's been shown that if you can open the artery within 90 minutes with a stent, that you do better. So if it's longer than 90 minutes, it's better to open it up with the thrombolysis. If it's less than 90 minutes, it's better to open up with the stent. Sorry?
But it's not reversible. Yeah.
No, well, the thrombolysis, no, you give an injection and it really intense thinning of the blood, you dissolve the blood clot and then it wears off. Streptokinase takes 4 to 6 hours to wear off. The newer agents wear off within a couple of hours. Yeah, but yes, but because you're using such a intense blood clot dissolving medication, increases the chances of bleeding. But it's again trade-off, risk and benefit. Yeah.
If you're on long-term channel blockers and the antagonists, and you're having ongoing side effects like palpitations, could that have a long-term effect?
Depends what they're due to. Palpitations are often benign. You get ectopic activity, and that's benign. And if it's that, if you get things like SVT or supraventricular tachycardia, that's benign, but we can fix it. If it's things like ventricular tachycardia, that's not benign, and you do something about it. And it's atrial fibrillation that's not benign. So it depends on what the palpitations are due to. But you know, with all of these drugs now, we've got so many alternatives. If you get a side effect with one, you say, okay, stop it and we'll try something different. So as I told you, there's lots and lots of agents available, and we just try and find the right drug for the right person, the right dose to keep the blood pressure down, but without causing side effects. So it's a matter of trial and error to some extent.
Would you say that hypertension is more lifestyle related as opposed to genetics, or is it balanced between the two?
A balance between the two. So we've got lots of patients who have very healthy lifestyles, eat good diets, thin, exercise, who have high blood pressure, and that's primarily they've inherited a tendency for that from their parents. And it's very seldom just one genetic defect, it's a whole combination of things. But if you've got that tendency and you're overweight, eat a lot of salt, don't do any exercise, eat crap food, that's just going to make you develop hypertension earlier than it otherwise would. Now, if you've got hypertension, generally we'd say with diet and lifestyle, you could reduce by about 10 on 5. So if you've got a blood pressure that's say 145 on 95, and you stick to a really strict diet, you might get it down to 135 on 90, which is acceptable, and that's fine without medication. If you've got a blood pressure at 180 on 100, you can diet all you like, but you're never going to get to your target level, so you need medication. So it's a matter of just basically seeing what you can reverse or intervene upon in the individual as to how much blood pressure reduction you're going to get with the lifestyle intervention.
And if you do go on blood pressure medication and your blood pressure, is resolved, I guess, will you be on that for life?
Generally, yeah. Well, unless something changes. So if you're a big fat person who eats badly, eats lots of salt, and you say, there's a carrot and stick, and sometimes you say to them, look, if you don't get your life together, I'm going to put you on blood pressure pills next time I see you. And sometimes that's a motivation for people to do it. On the other hand, you might say to people, I'm putting you on pills, and if you lose all that weight and you stop eating salt and cut back your alcohol, I'll take you off the pills if your blood pressure comes down. Now, sometimes that doesn't work, but that's the sort of strategies you use to try and motivate people to change their lifestyles. But as I mentioned, there's lots of people who have very healthy lifestyles who still have blood pressure, and medication is the only way to go.
Is there like a nationality that I'm more prone to having high blood pressure? Like Europeans, they have a lot of salt in their diet.
Not so much Caucasians, but African Americans and Africans in general do tend to have a higher prevalence of blood pressure than Caucasians. There's debate as to how much of that's genetics as opposed to diet, because African Americans tend to have a very high salt diet, tend to be overweight, tend to be physically inactive, and so some people will say it's a environmental thing that pushes blood pressure up. Others will say it's inherent in their genetic makeup from when they lived in Africa, where they didn't have ready access to food, so they tend to eat a high salt diet there. So it's not clear, but certainly African Americans seem to have a higher prevalence of hypertension than Caucasian counterparts. Otherwise, Asians maybe a little bit, but Caucasians pretty much the same.
Just on diet and exercise and that, do you mind just touching a little bit on lipid lowering therapies?
Sure. Okay, so again, lipid lowering, we're talking about elevated cholesterol primarily, and we know there's a population level that the higher your cholesterol is, the more likely you are to have a heart attack or a stroke. And basically, but there's a lot of overlap. We see a lot of people with high cholesterol that have nothing wrong with them, and we see a lot of people who have normal cholesterol who have a heart attack. So there's overlap between high cholesterol, between people with high cholesterol with nothing, etc. So generally, if you've had a heart attack or a stroke, we say whatever your cholesterol is, it's too high for you, and so we lower it with what's called a statin, and that's standard therapy. So even if your cholesterol's 4.5, which is normal, you'd say if you've had a heart attack, you've got to be on a statin to get it lower. And we think the lower you get it, the better it is, and the less likely you are to have another heart attack or stroke. The commonly used agents are called statins or HMG-CoA reductase inhibitors. They work by stopping intracellular production of cholesterol and will drop your cholesterol by 40 to 50% depending on the agent and the dose you use. The most common side effect with them is people get a bit achy muscles. If it's really bad, you can get actual inflammation of the muscles and muscle necrosis, and that's pretty ugly, and people can die from that, so you have to be aware of it. But that's a minority of people. A lot of people say they get achy and their blood tests are normal, and they stop the statin, it gets better, they start it, it gets worse. Maybe 10% of people get that, and again, it's a matter of then trading off. If you've had a heart attack or a stroke, some people say, okay, I'll put up with that because I know I'll reduce the risk of another event. Others, if you're using it particularly for, say, primary prevention or to prevent it, they'll say, I don't like it, this feeling, and I'll go off it. The other agent to lower cholesterol is one called ezetrol, which is an agent that blocks absorption of cholesterol in the gut, and it basically works very well in conjunction with statins because the statins stop you producing it, ezetrol stops you absorbing it, so together they work very well. The only other agent that's on the market, the other newer agent are what's called the PCKS9 inhibitors, which are injectable agents that you have one injection every 2 weeks. They lower your cholesterol by 60% to unheard of lower levels. They're very good. They reduce heart attack, they reduce stroke, but they cost $800 to $1,000 a month, and the government says we're only going to allow you to use them in very special circumstances, and so as time goes on they'll get cheaper, but they are really effective but way too expensive for use in the general population. The other agents are called fibrates, which is gemfibrozil or fenofibrate. They work primarily on triglycerides and HDL and are good complementary medications, but haven't got good outcome data in terms of reducing heart attack, stroke and death in patients with heart disease. But we use them particularly in diabetics to change their, what they call atherogenic dyslipidemia, to improve that. Okay.
With those injections, once your cholesterol reduces to an appropriate level, do the injections stop or are they?
No, again, lifelong.
Wow.
It's the same thing. If you drop your cholesterol and you go off it, it just goes back up to it. The same with blood pressure, unless there's lifestyle things you can do to change it. But generally, the people we use it for are what's called familial hypercholesterolemia. So they'll have a cholesterol of 10, 12, 13, 14, and their statins only get it down from say 14 to 10, and you're still at risk. So these will really work in that very uncommon patient population, and they're very effective, but they're basically too expensive at the moment for general use.